Petra, and thank you everyone for coming. I'm glad you skipped coffee to be here with me. I understand that we have a very short window in this morning break, so everybody's running around, so I'm happy that you're all here, and I hope you like what I'm going to tell you. So I will try to make it as fast as possible, and so we can have coffee afterwards. So you all know that is very bad for you to be a monochorionic twin. Yes, if you are monochorionic twin, you have very high rate of pregnancy complication compared to dichorionic twin, even more compared to a singleton pregnancy. So it is dangerous for you to be a monochorionic twin. Most of the reason why you have that, it's because of this unique placental architecture that we have that allows for communication between the two babies and to share the circulation. So they share the placenta, but they also share the circulation. And some of the communications are more dangerous than others. As you know, you have the ones that are unidirectional, like the arterial venous communications, and these allow for a very common complication that we know is the twin-to-twin transfusion syndrome. It's very easy to spot when you have a severe twin-to-twin transfusion syndrome. We have one baby that has a lot of fluid, the other baby, which is the recipient, the other baby has very little or no fluid at all. And this is because in twin-to-twin transfusion syndrome, what you have is a massive shift of volume. You don't need to be small, you don't need to have anemia, you just need to have a massive shift of volume from one baby to the other. And when we do that, we know that beyond the vascular anastomosis that allows that, there are some other fetal defense mechanisms that are active. Some of the ones that we know are related to renin, angiotensin, and aldosterone activation. We know that the baby that has less fluid becomes hypovolemic, and because it becomes hypovolemic, it activates. We're not going to go through that. I mean, nobody wants to know that. You activate the renin, angiotensin, aldosterone system, and because of that, it creates all the defense mechanisms that the donor baby, because it's hypovolemic, needs. On the other hand, the recipient becomes hypervolemic and does the opposite. It deactivates that and deactivates other complexes, other cascades that helps to deal with the hypervolemia. So we know that beyond the vascular anastomosis, beyond the architecture between both that allow the communication between both babies, you have some other mechanisms, defense mechanisms that are behind that. So we went to think of what else could be playing a role in twin-to-twin transfusion syndrome. And so we went to study something called the hepatic arterial buffer. Have you ever heard of the hepatic arterial buffer? No. But the hepatologists, they know it very well. We all have this buffer. What happens, it's very, very, very simple. We all have a liver for a while. And in our liver, produce adenosine, all of us. And adenosine is produced at a constant rate. Yeah, so you have adenosine being produced now. And whenever the blood comes into the liver, it washes out the adenosine, so it keeps it in balance. Yeah? If you have less blood coming into the liver, adenosine builds up in the fetal liver, and when it builds up, that it acts as a vasodilator of the terminal branches of the hepatic artery. So it allows more blood to flow through the liver, through the hepatic artery. This is called the hepatic artery buffer. We all do that. Whenever you have hypotension, you activate that. So it's active in grown-ups and kids as well. If you have more blood, then you have more washout, then you have less adenosine, so there is no opening, okay, of the hepatic artery. So we look into that and see, well, that's sort of what's happening here in twin-to-twin transfusion syndrome. We have a baby that is the recipient that receives more blood through the umbilical vein. You have one that is the donor that for sure will have less volume coming through the umbilical vein, so you may have an active buffer there in this baby. So we went to look at the hepatic artery, and it's very easy. Now that you have seen that, on Monday morning next week, when you start scanning back again, you will see that's very easy. From 12 weeks onwards, you can easily see the hepatic artery. Yeah, you have here, that's the video there, but here is easy to see. You have the heart there, you have the umbilical vein, the ductus venosus, that's the aorta, that's the hepatic artery right there, and that's the left hepatic artery. It seems that it joins up with the umbilical vein, but actually it goes behind to the liver. So it's very easy to see. And it's very easy to measure as well, because if you put a caliper here around this area, you always have the measurement that. In the video, it makes it very easy to find, okay? One very interesting thing about hepatic artery is there is no report on absent hepatic artery. So there is no report on absent hepatic artery. So because it just increased the significance of the buffer in the human being. So we went to look into that. And our first study was published last year. And we create something that we call the HAV ratio, the hepatic artery velocity ratio, where we divide the recipient by the donor. And we found that this ratio has no correlation with gestational age, no correlation with fetal weight, and no correlation with any other doublers. We look into low numbers, 64 monochorionic twins, 43 normals, 21 abnormals. This was a prospective study. And what we saw was that the ratio was much lower in monochorionic twins with twin-to-twin transfusion syndrome. This was significantly lower. The non-TTTS ratio was about 1.02 because you expect that the flow would be the same between both. But when you have the TTTS, you have a much lower rate. So we show that apparently the buffer was active. And then we went to a second study that we just recently published, actually, to study what was going on into the recipient and into the donor to see if the hypothesis that we had that the buffer would be active in the donor would be true. So we were looking to a little bit more, so 118 monochorionic twins, 73 normal, 45 abnormals. This was with repeated measurements, so we had 383 assessments in normal and 115 in abnormal. And in what we look here is that this is, so when we look at the hepatic artery, not the ratio, when you look at the hepatic artery is mildly affected by gestational age. But if you want to compare 16 weeks and 26, you need to correct by the gestational age. So what we've done, we created Z-scores. And then we call that, because we like to call cool names, we call that the HAV-Z. It's cool, right? So it's hepatic arterial velocity Z-scores, okay? So we measure the Z-score in the individual fetus, in the recipient and the donor. So this is the normal. And when we compare recipients to the normal, there is a tendency to be slightly lower, but it's non-significant. But the donor is much, much higher than the normal when you have TTTS. So this is the normal, this is the donor. And then we will consider, is this by chance that is happening, or this is a specific effect of the twin-to-twin transfusion syndrome? So how do we go about proving that? So we went to look and pre-lasers and post-lasers. So we had 45 pre-lasers donors and 42 post-laser donors. And we compare that, and we see that compared to the those are donors, compared to the pre-laser donors, you have a significant reduction in the Z-score of the hepatic artery. So it just shows that the hepatic artery buffer is active in twin-to-twin transfusion syndrome. It is active mainly, of course, in donors, because we know what's going on in donors and it makes sense to be active there. And not only is active there, but it is a specific response to twin-to-twin transfusion syndrome. And after a successful laser, the hepatic artery buffer reduces. It does not reduce to a normal levels, but that may be related to the timing where we measure. We measure after the post-laser, the day after the laser. So it's possibly that if you carry on measuring along the line, you will see that the reduction may be even more. Or maybe it doesn't reduce completely because it's still related to the catch-up of the baby. We can discuss that later. So it's an interesting concept that shows us that there are much more things involved in the twin-to-twin transfusion syndrome that we nowadays suppose. You have, of course, the connection between the two babies that are very important, but beyond the connection between the two babies that are important, you also have some fetal defense mechanisms that are activated as the renin, angiotensin, and aldosterone. And here we show that you have the hepatic arterial buffer active during twin-to-twin transfusion syndrome. Those are important concepts because we pretend that we understand a lot of the twin-to-twin transfusion syndrome, but in fact, we don't really know what's going on. That's the reason why we follow monochorionic twins every 2 weeks, because we fail to understand, to predict. And we fail to predict because we don't really understand very much the pathophysiology of this disease that we still call a syndrome. So the importance of this buffer is that one step more where we can actually try to understand what's going on in those babies. So for a take-home message, there are different pathophysiological defense mechanisms that are involved in twin-to-twin transfusion syndrome. Maybe we should get to know them. The hepatic arterial buffer is an important defense mechanism for adults, for children, and apparently it's a very important defense mechanism also for fetuses. And in TTS, it is active. The half ratio, it's a very easy way of studying the activation of the hepatic buffer because the ratio, it's not affected by anything else, not affected by any other Doppler, it's not affected by fetal size, and it's not affected by gestational age. So it's very easy to interpret. And so the ratio is lower in TTS compared to normal pregnancies mainly because of the activation of the hepatic artery in the donor fetus. So you have an increased blood flow in the donor fetus, and because in the ratio the donor is the lower part, so you have an increased one. And it shows that it is a specific effect during twin-to-twin transfusion syndrome because after the laser it reduced. So I thank you very much for your time, and I hope you enjoy this new defense mechanism. And we are open to question, I guess. Thank you very much.